Good morning, everyone. Welcome again to our E&M Teaching Physician Guidelines webinar. My name is Ashley Decoto, and I am a specialist with our Provider Outreach and Education team. On the call with me today is my friend and colleague, Leanne Foster, who you just heard from. Leanne is going to be helping out with the chat today. We will have a recording of this session available in the Training Center on our website, and Leanne will be adding a link for the Training Center to the chat. It will be available on our website for the next 60 to 90 days, barring any technical issues with the recording. And you can access this without having to access YouTube, as we do recognize that not everyone is able to access YouTube from work. The recording will also be available on our YouTube channel, as long as the information remains relevant and current. Also in our training center, you can find a copy of today's presentation. So if you haven't already grabbed that, it is still available for download if you would like to have the presentation to maybe follow along or to take notes, though it's not required. We are taking questions through the chat today, which again, Leanne will be monitoring. I will check in with Leanne at the end of the presentation, time permitting, for any questions in the chat. I will also be answering those questions that were pre-submitted with registration throughout the presentation today. So here we have our agenda for today. I'll be providing information on evaluation and management teaching physician guidelines, including the teaching physician's presence, documentation in the medical record, and the primary care exception requirements. We will not be covering facility payments to teaching hospitals, such as the direct graduate medical education, or DGME, or the indirect medical education, or IME payments. Today is all about the rules for documenting and billing the professional E&M service, meaning the visit itself, not how the hospital is reimbursed for the residency program. Also, we did have a pre-submitted question asking about Incident 2 billing requirements. And we will not be covering Incident 2 services in today's webinar, but Leanne and I did a two-part series on Incident 2 services back in August, and I've asked Leanne to place links in the chat for the recordings of those webinars. This slide contains the acronyms that I will be using today, and I've gathered these all in one place so that you have this for reference. And some of you may be familiar with these, but I did include these as we may have some attending who are a little bit newer to billing Medicare and maybe not as familiar with these acronyms. Again, if you've not already downloaded today's presentation, it is still available in the Training Center on our website, and you'll find that under Live Events. So feel free to download that, and then you'll have this acronym slide as a reference. So first, let's talk about evaluation and management services provided by residents and by teaching physicians. This slide gives information on payment for residents. Medicare does not make direct payment to residents other than when they are moonlighting, which I am going to talk about later in the presentation. Payment for resident services is part of the Direct Graduate Medical Education Program, or DGME, or Indirect Medical Education Program, or IME. Now, services provided in order to teach the resident how to provide medical services is under payment to those teaching facilities, who will report on all of the costs incurred in teaching those residents. Then the facility is responsible for making payment to the resident for their salary and fringe benefits for services provided by the resident in the hospital and non-provider settings, such as a clinic. We had a pre-submitted question asking if this applies to podiatry residencies. and it could apply, but they would have to meet the guidelines. So the facility would have to be receiving the graduate medical education, or the GME payment, for those residents' salary and fringe benefits. And if it does meet those requirements for the teaching facility, then the requirements could apply for podiatry. Another pre-submitted question asked, when fellows are considered a resident. And I want to take you out to the Medicare Claims Processing Manual, Chapter 12, to answer this question, which is one of the links on the resource slide of this presentation. So this is the Claims Processing Manual, Chapter 12. And the information I want to show you is in Section 100, which you can find either by scrolling down in the table of contents, or I know that it begins on the bottom of page 137. The first part of this section, Section 100, provides definitions as it relates to Medicare teaching physician guidelines. So we have the definition of a resident, student, teaching physician, etc. What I want to look at here is the definition of a resident. So Medicare considers a resident to be either one who participates in an approved graduate medical education program. So this would be those residents who are able to provide services under the teaching physician guidelines we're discussing today. Or a resident could be a physician who is not in a GME program, but authorized to practice only in a hospital setting. So those residents would not meet our teaching physician guidelines. The definition then goes on to tell us that this includes interns and fellows in GME programs, and that participating in a fellowship does not change the status of a resident. So for Medicare purposes, if a fellow is enrolled in a GME program, they are considered to be a resident. Also in this manual, if I scroll down past the definitions, I'm going to go to page 139. A little bit more, here we go. There's a section here on evaluation and management services, which is section 100.1.1. So you have general documentation requirements here, which provides information on what the teaching physician must document. And then we have this section on documentation provided by students. And then the last one I'll point out is the exception for E&M services furnished in certain primary care centers. And I'm not going to go through this whole manual, but I did want to point these sections out, which have information related to what I'll be presenting today, in case you want to refer back to this manual later. So I'm going to head back to the presentation. So now let's look at payment for teaching physicians. Medicare payment to teaching physicians is for the work that is done by that teaching physician in the care of a patient. So payment is made for services provided by the resident when the teaching physician is present during key and critical portions of the service. Now for evaluation and management services, this would be really for the entire service, whether you're using time or medical decision-making to choose your level of service. Medicare also has a primary care exception, which pays for the teaching physician's involvement and supervision of the resident providing care to that patient. And I'm going to talk again more later about the primary care exception later in the presentation. So when a teaching physician is providing services in a teaching facility, if they are not involving residents in their care of that patient, then they would just bill the services to Medicare like normal, following all of the regular Medicare rules and regulations for evaluation and management services. Now, when the teaching physician is involving the resident in the care of their patients, the teaching physician does need to be physically present during the key and critical portions of the service. So in these situations, the patient would look to that teaching physician as their provider. So the patient is going to a clinic, and the teaching physician is really the one who is responsible for that patient's care, but they are supervising the resident. When this criteria is met, the teaching physician bills the evaluation and management service with the GC modifier. The GC modifier tells Medicare that the service was provided by a resident, but under the direction of that teaching physician. We had a question on the GC modifier, which was when a resident and an MD are in a wound clinic that is not part of the resident program, does the GC modifier still apply? And the answer is no. The GC modifier would only be used for services provided by the resident in a teaching facility that is receiving payment as part of the graduate medical education program. Services provided by a resident outside of a GME program are called moonlighting, which we'll talk about here in a little bit. But the GC modifier would not apply in those situations. We did have a few questions asking if this would apply for federally qualified health centers or FQHCs, and yes, this could apply. So the facility, would have to be receiving payment from a graduate medical education program, and modifier GC may be used for services provided by the resident when the teaching physician is physically present for the service. So the teaching physician, again, is the one who is primarily responsible for the patient's care. They must be physically present while the resident is performing the service, meaning they must be right there in person with the resident. There is an exception to in-person supervision, which is when the training site is located outside of a metropolitan statistical area, or MSA. An MSA is defined as a geographic area based on a county or a group of counties with at least one urbanized area with a population of at least 50,000 and adjacent counties with economic ties to the central area. So if you're in an area meeting this definition of an MSA, you must have the physical presence of the teaching physician, meaning they need to be right there in person with the residents. Now, if you're outside of an MSA, the exception to the in-person supervision requirement outside of an MSA allows for supervision to be done via two-way audio-video communication. And you want to make sure the documentation demonstrates that the teaching physician was virtually present to supervise these services outside of an MSA. For services that the resident is providing via telehealth, the teaching physician's presence may be through two-way audio-video communication. The patient may receive telehealth services from their home only through January 30th of 2026. CMS has recently updated a telehealth FAQ, which addresses this. It does tell us that beginning January 31st, for non-behavioral health services, beneficiaries will need to be in a rural area, meaning outside of an MSA, and in a medical facility to receive telehealth. We did have a pre-submitted question asking about 2026 updates. So CMS has published the 2026 final rule, which does address this telehealth requirement. And I encourage you to review that publication, which you can find on the cms.gov website if you do a search for 2026 final rule. And I do find that the telehealth FAQ, which I have linked here on this slide, this was updated after the final rule came out, and I feel like it provides a bit more information on virtual presence for the teaching physician. So I would take a look at that one too. We won't be going into any more detail on telehealth today for the sake of time, but our colleague Mary, she did a webinar on the overview of Medicare telehealth, past, present, and future that you may find helpful. And I've asked Leanne to place a link to the recording of that webinar in the chat. Leanne and I are also planning a webinar on E&M telehealth services in late February after the flexibilities expire. So keep an eye out for that. Next, I want to talk a little bit about documentation requirements for teaching physicians. And we had several pre-submitted questions regarding documentation that I will be addressing in this section of the presentation. The medical record must demonstrate the responsibility of the teaching physician. So the documentation must include an attestation or a statement to reflect the teaching physician's presence during the key and critical portions of the service. The teaching physician's presence may be documented by other members of the medical team, such as the resident or nursing staff, but must be signed and dated by the teaching physician. The attestation should be done at the time of documenting the service, but if for some reason it's done later, you must show why it was added late. We had a pre-submitted question which asked, what is the teaching physician required to document on the resident's note? When the resident is providing the service, the medical record must show that the teaching physician was present for the service. Again, this can be an attestation statement, and it can be done by the teaching physician, or could also be done by the resident or by nursing staff who were there at the time of that service. The teaching physician must also sign the resident's medical record. Another pre-submitted question asked how detailed the attestation statement needs to be. It needs to be detailed enough so that these requirements are met. If that documentation were pulled for review, would a clinical reviewer be able to determine the teaching physician's presence and their involvement during that service? So just signing the record would not be enough. The statement would also need to indicate the teaching physician's presence and how they were involved. Medicare does not have a template for this, so the attestation statement will be specific to what the teaching physician did. And I would stay away from statements like, I agree with the above, because that does not clearly show if they were present and how they were involved in that service. Again, CMS nor the MACs have templates, which allows the flexibility for physicians to indicate specifically what their involvement was in each scenario. Another question we received was, does the teaching physician need to provide a separate identifiable note if the resident does not document the teaching physician participation? And the answer is that the attestation of presence, again, can be documented by the teaching physician, resident, or nursing staff. If the resident does not document this, it can be documented by the teaching physician or nursing staff that were present during the visit. Now remember that the attestation statement should be done at the time of documenting the service. And if it's done at a later time, the documentation would need to include the reason for that late entry. We had another pre-submitted question regarding documentation, which was, can providers pull over or copy from visit to next visit, and what must be updated, including time? CMS does not prohibit cloning from a previous record, but we do caution providers to ensure that the documentation from that encounter accurately reflects what occurred in that encounter. So we need to have documentation from the encounter itself. Are the clone notes from one encounter being used to document the services for a different encounter? And if they are, how is it documenting the current encounter? Because we would guess that the same thing did not happen in both encounters. And this can lead to inaccurate documentation. So again, be very cautious using this process. It's probably not going to be your best practice. The documentation must be for the encounter that is being billed. Next, your documentation must support the level of service chosen. So if you're using time to choose your level of E&M service, your documentation must support the level of service chosen using time. For E&M services, you are only including time spent by the physician. And this may include face-to-face time with the patient and non-face-to-face time. So if the teaching physician and resident are discussing care specifically for that patient, then that time counts. But general teaching time does not count. Excuse me for just a moment. My apologies, I had a little tickle in my throat. So you may also choose your level of service using medical decision-making, which follows CPT guidelines. The teaching physician must be present for all elements of medical decision-making, including while the resident is gathering the problem, the data, and the risk for that patient. The documentation must support the level of service chosen using medical decision-making. We had a couple pre-submitted questions which asked for tips for physician education on documenting medical decision-making. If you're asking for information on choosing your level of service, Leanne did a webinar on this where she went into detail on choosing your level of service based on either time or medical decision-making. And I've asked her to place a link in the chat to the recording of that webinar. We had another pre-submitted question on how best to advise providers to document the severity level of risk. Again, I would encourage you to review that same video on choosing your level of service, as we're not going to go into detail today on medical decision-making. Another pre-submitted question asked, can a provider bill a consult visit more than one day after seen by a resident physician? So a provider can bill a medically necessary E&M visit in this situation, if that's what this question is asking. The consult must be medically necessary, and the documentation must support the level of service billed. Now for Medicare, consults or consultations are just billed as an E&M service. Now this answer is assuming that this is not someone checking on the resident's work. If the teaching physician is checking the resident's work, that would not be a separately billable service. We had another question on documentation, which was, can teaching physicians change the resident's note and sign the record? The teaching physician must review and sign their agreements with the resident's note. And if they find that the resident failed to document something, they may choose to make adjustments before signing their agreements. Keep in mind, though, that amendments must not introduce new information. Rather, they should clarify existing information within that record. And the amendment must be properly annotated so that the original content is still there and it's clear what was changed. All right, next, I'll talk about the primary care exception. So let's start out with an overview. The primary care exception allows the resident to provide care to a patient without the teaching physician's presence. So the teaching physician must have no other responsibilities and cannot supervise more than 4 residents. We have the GE modifier, which is used for services performed by a resident without the presence of a teaching physician under the primary care exception. We did have a pre-submitted question which asked if the GE modifier should be used for inpatient settings, and the answer to that is no. The primary care exception only applies for outpatient services, so the GE modifier would not be used for inpatient services. Here we have the requirements for the primary care exception. So the service must be provided in a location where resident time is counted towards the graduate medical education program, such as the outpatient department of a hospital or an outpatient clinic. The resident must have completed more than 6 months of an approved residency program. And the teaching physician must be immediately available to assist if needed, meaning they should not have any other responsibilities, like I mentioned on the last slide. A great example of that would be, think of a physician set up at a desk in the hallway with residents caring for patients in each of 4 separate rooms. Then if they need to step out for input from the teaching physician, he or she is right there available to provide that input. The teaching physician must review the care provided by the resident either during or immediately after that visit. And that outpatient setting must be the patient's primary source of health care. We had a pre-submitted question asking, is there a way to look up if a clinic is a registered primary care exception or PCE clinic? And the clinics need to maintain record of their status as a primary care exception facility. There's not a central registry for primary care exception clinics. So the primary care exception only applies to those lower level E&M services, which are listed here. So these are your outpatient E&M codes, 99202 to 99203 and 99211 to 99213. You must use medical decision-making to select your level of service under the primary care exception. You're not able to use time under the primary care exception. There is another resource that I'd like to show you for the primary care exception, which is the CMS MLN booklet on guidelines for teaching physicians, interns, and residents, which is also linked on the resource slide. So I've opened that MLN booklet, and I'm going to scroll down to the second page where I'll find this table of contents. And here we see all of the information that's included in this booklet. So you have information on teaching physician settings, there's medical record guidelines, E&M guidelines. I'm going to click on this section for E&M services primary care exception, which will take me right to that section of this booklet. So there's a few things that I want to point out here. First, we see here in this third paragraph that you're not able to use time again to select your level of service under the primary care exception. Again, you can only use medical decision making. Next, I want to scroll down and take a look at these tables. Here we have the new patient and the established patient codes for evaluation and management services that are acceptable under the primary care exception. Now notice in the chart below that, we also have annual wellness visits, and these codes were not listed on your slide since our focus today is evaluation and management, but I wanted you to know this was here and that these annual wellness visits are also acceptable under the primary care exception. I'm going to go to the top of the next page, which is where we really get into the detailed requirements for the primary care exception. And there's a few key things I want to highlight in this section. We have this first bullet and the note just below it that tells us these services apply again in the outpatient setting, such as an outpatient hospital department or another ambulatory care entity. So for example, this could be an off-site clinic. Below that, in this next bullet, we see that the resident must have completed more than 6 months of an approved residency program. And then the last thing I'll point out in this booklet is in the next bullet, which talks about the teaching physician's responsibility. And I touched a little bit on this, but here it tells us that they may not supervise any more than 4 residents at a time under the primary care exception. So their only responsibility is going to be supervising those residents. They're primarily responsible for each of those patients and must make sure that all care provided is reasonable and necessary. The teaching physician must review the resident's care, again, either during or right after that visit, and then they'll need to document what their involvement was. That's all I'm going to point out in this booklet for now, but I did want to make sure you knew this resource was available in case you want to refer back to it for some light reading on teaching physician guidelines. All right, let's head back to our presentation. So now I have just a few additional teaching physician guidelines I want to share before I check in with Leanne. Here we have some information on students. Students must be in the physical presence of the teaching physician or resident. Remember, Medicare does not pay for services furnished by students. The Claims Processing Manual, Chapter 12, where we looked earlier at those definitions, has Medicare's definition of a student, which is an individual who participates in an accredited educational program, that's really a tongue twister for me, such as a medical school, and is not in an approved GME program. So students are never considered by Medicare to be interns or residents. Students may document services in the medical record. However, the teaching physician must perform or re-perform all elements of the service and verify the information documented by the student. Now, the teaching physician does not have to redocument what the student has documented, but must attest to their agreement and identify any changes made. So it needs to be clear to a clinical reviewer that the teaching physician has performed all elements of that service. Next up, we have moonlighting. Moonlighting is where the resident is actually providing services outside the scope of their graduate medical education program. And it could be within that same facility, but separate from the GME program, or it could be in other facilities outside of the GME facility. So moonlighting includes services that are not related to a resident's training program, meaning the service can be separately identified from those services that are required as part of the training program. If the services are outside of the GME program, the resident would need to be fully licensed by the state and enrolled with Medicare as an MD or a DO. They would then be able to submit medically necessary services to Medicare, following all normal Medicare rules and regulations. We do have a resource on our WPS GHA website that has information on physicians and residency programs, which outlines these moonlighting requirements. And I did ask Leanne to place a link in the chat to this resource. So let's actually go out and take a look at this one. So in this resource, there's a few things that I want to point out. This top section here for resident services furnished within the scope of approved training programs just tells us again that payment for resident services is included in the facility's Part A reimbursement for the graduate medical education program. And this ties into what I covered early in the presentation, where the hospital is then responsible for paying the resident's salary and fringe benefits. For E&M services that are provided in part by the resident, and the teaching physician is physically present and responsible for the care of that patient, those are situations that we talked about where the teaching physician may bill for that E&M service with the GC modifier. All right, so now let's look at moonlighting, which is in the next section. If I scroll down some, resident services furnished outside the scope of approved training programs. So for services furnished outside the scope of the GME program, we have two different scenarios. Either it is furnished outside of the hospital where they have their training program, or the service is done in the outpatient department or emergency room at the facility where they have their training program. So each of these sections gives us the requirements for the residents to bill those services. So they must be identifiable physician services, meaning these services must be medically necessary for the diagnosis or treatment of that patient's condition. The resident also has to be fully licensed in the state where the services are provided. Now, the key difference I'll point out here is in the third bullet under services that are performed at the facility where they have their training program. For those services to be billable to Medicare Part B, they must be separately identifiable from services that are part of their training program. So it really must be clear that this service that's performed by the resident at the same teaching hospital where they have their program is being done outside the scope of that program. I want to show you one more thing on this page. If I scroll down a little bit, which is this section on residents enrolling in Medicare Part B. And this gives you some general information on requirements to enroll in Medicare Part B. If you're looking for more information on enrollment, because I know there's a lot to it, we do have a playlist on our YouTube channel specific to provider enrollment. And I encourage you to take a look at that. All right, I do have one more thing I'd like to show you on our website while we're out here. So I'm going to scroll back up to the top of this page, and pardon my scrolling, and I'm going to click on Topic Center, which expands this menu, and I'm going to click on Claims. What I want to show you is our modifiers page, which I could scroll through this alphabetical list to find, or if I start typing modifier here, that will pop up for me. So here's our modifiers page. And this has the most common modifiers that are kind of organized by category, each with a hyperlink to a fact sheet for that modifier. And I'm going to continue to scroll down until I find resident modifiers. And you see here we have fact sheets for the GC and the GE modifier. And I'm going to click on the GE modifier fact sheet just to give you an idea of what you'll find in our modifier fact sheets. So you have the definition of this modifier up top. Then we have the definition of the primary care exception, which I've talked about. Then we have teaching physician requirements. Then I'm going to scroll down a little bit. And here we have appropriate usage, such as lower level E&M codes or annual wellness visits. Then we have inappropriate usage examples like billing for services that are not part of the primary care exception. And you will find appropriate and inappropriate use examples on most of our modifier fact sheets. Then at the bottom of each modifier fact sheet, you can usually find links for resources with additional information in the reference section. And notice here for the GE modifier fact sheet, there's a link to the Medicare Claims Processing Manual, Chapter 12, which is that first resource that we looked at today. So whether you're billing for teaching physician services, or maybe you're a resident who's newly enrolled to bill Medicare, I encourage you to take a look at our modifiers page. There's also a group there of evaluation and management modifier fact sheets that you may find helpful. All right, I'm going to head back over to our presentation and move on to our resources, which we've looked at for the most part. All right, so for our resources, first is the CMS resource on the guidelines for teaching physicians, interns, and residents. And this is the MLN booklet where I showed you that section on the primary care exception requirement. And this resource, in my opinion, this is really the most comprehensive and I think easiest to understand for information on teaching physician guidelines. So that's a great one to take a look back at. And then next we have the Evaluation and Management Services Guide. This one can really be your go-to for all things evaluation and management, and it does include a section on teaching physician services. And then lastly, we have the Medicare Claims Processing Manual, Chapter 12. That's where I went earlier to show you the definitions in the section on teaching physician guidelines. All right, now I'll check in with Leanne. Leanne, do we have any questions in the chat?
I've been answering some as we've gone along, but we do have a few questions. The first one is asking about the teaching physician's attestation. So the question is, if they make their attestation within the resident's note and the resident appears to be the author of the note for the date of service, how would a reviewer know that the teaching physician actually wrote the attestation in the resident's note? They're indicating that the EHR system does not have a separate date timestamp or teaching physician signature line for that attestation. The note would not show the teaching physician as the author of the attestation. So the follow-up question is asking, would the teaching physician have to provide a separate note in the EHR to demonstrate their presence and meet the guideline?
This sounds like if the resident has already finalized that note and has signed that note, and the teaching physician is adding in that attestation statement, they're making a change to that signed record, and there would need to be note of what change was made. So it would need to be properly annotated with the date and at least the initials of the person making that change. So the teaching physician in this case. And Leanne, if you have anything to add, please feel free.
No, I don't. All right.
Anything else?
Next question is, do the teaching physician guidelines apply when it's a resident or is a fellow instead of a resident?
So that ties into the definitions that we looked at back in the Medicare Claims Processing Manual and how CMS defines a resident. And yes, if a fellow is enrolled in a graduate medical education program, they can be classified as a resident under these requirements. Next question.
Next question is, can a resident moonlight in a wound clinic? Can the resident perform wound care without a teaching physician present? And I can actually take that one if that's okay, Ashley. The answer to that is yes, the resident can moonlight in a wound clinic, provided that they are fully licensed and the services are outside of the scope of the residency training program. So that's really the key with moonlighting. It has to be outside of the scope. If they're in their residency for the wound care and they're not fully licensed for that, then they would not be able to do so.
All right, any more questions?
There is one more. This question is, I believe, a follow-up from the documentation a little bit. And it says that CMS's MLM booklet shows that in a GME situation, that the documentation must demonstrate either that the teaching physician performed the service or was physically present during the key and critical portions that were provided that were resident provided for that service or procedure. They're indicating they did not hear or see the first option in the presentation. So I think they're just confirming what's in the MLM booklet.
Yeah, the information in the MLN booklet is correct. So really what we focused on here was situations where the resident is providing the service, but you may have cases, or you probably do have cases, where the resident is going to provide a portion of that service and maybe the teaching physician is providing a portion of the service. Just make sure that the documentation is clear on what the teaching physician's involvement was in that service and that they sign their agreements with that note. Anything else?
Those are, oh, there is one that came in. The next one is, and this is the last question that I have at the moment. It's asking if a resident simply observes the patient encounter and the entire service is provided by the teaching physician, do we need to apply the GC modifier?
And you said that was the last one we have in the chat right now?
Oh, I'm sorry. Did you hear my last question about the GC modifier? I apologize. I might have been on mute.
I did. No, they would not need the GC modifier in that.
All right. That is the last question in the chat.
All right. All right. Thanks, Leanne. We will move right along. Few things while we wrap up. If you do think of any additional questions, you have 7 days from today to submit those. And you'll send those to our education mailbox. And make sure to include the title of this webinar, E&M Teaching Physician Guidelines, in the subject line so that they make sure those emails come to me. Keep in mind that I'm not able to access any claims history, so you will want to contact customer service for any claims related questions. In a few minutes, you will receive an email to thank you for attending, and you don't want to delete this one without reading it. The email contains your certificate of achievement, so it will have your name and your contact hours if you need to turn that in for credit towards continuing education units. If you do not receive the email, a few things may have happened. First, you may want to check your spam or junk folder. Also, make sure to add messenger@webex.com to your safe sender list so that any future messages will show up in your inbox. Also, if you joined by phone only, you would not have received this email, as there's not a way for us to capture your emails systematically from our attendance record, but no need to worry. If you joined by phone, you are able to email us with the phone number you joined with to request your certificate of attendance. And Leanne will be adding that email address to the chat. All right, please take a few minutes to complete the survey. Tell us what you liked, what we can do better, and suggest topics for future education. You'll have a few different options to take the survey. You can use the link in the chat, or when you exit today, you will be prompted to go to an external site, and that external site is the CMS Qualtrics page. And the prompt will look like this picture we have here with a little yellow triangle. And we included that image on the top right of this slide so that you know this is safe. It's not malware or anything like that. For those listening through our website or through YouTube, you will also have the same opportunity to provide feedback. You will have a survey card at the end of the presentation, and you can scroll to the end to see that link. All right, that does conclude our webinar. On behalf of myself, Leanne, and all of Provider Outreach, we thank you for taking the time to join us today on a Friday. We look forward to your survey feedback and hope to see you again at future events. Everyone stay warm and have a wonderful weekend. You may now disconnect.